Good morning, guys. Miss Bowles here. I am recording some lectures in the hopeful event that my grandson decides to make his appearance soon and that I may not be able to be with you in class. So today, the first thing that we are going to discuss is inflammatory bowel disease, and we're starting with that's it from our Module 10. So, as usual, we have our normal exemplars. So it's good to know all of these: pathophysiology, etiology, risk factors, clinical manifestations, diagnostic tests and therapies, the different kinds of patients with inflammatory bowel disease, and also the nursing process. So we'll start with an overview. I like this picture here, and hopefully you can see okay. So one of the things that you'll need to do is be able to differentiate between Crohn's disease and ulcerative colitis. Those are the two different types of inflammatory bowel disease. Both of them are inflammatory conditions that have times of remission where things are okay and they're not having any symptoms at all, and then flares of active disease where they have a lot of symptoms. But there are things that make them distinct as well. So the classification is based on how bad the symptoms are and the number of bowel movements in a day. And then this just gives you a picture of what the colon looks like, what the bowel looks like with the different diseases. So with Crohn's disease, you can actually have involvement pretty much anywhere from the mouth all the way to the anus. But the places where we normally see it would be the ascending colon, like here, the transverse colon, and the descending colon. In ulcerative colitis, you see it's more in the descending colon, the sigmoid colon, and the rectum. Ulcerative colitis, about twice as many people develop that as Crohn's disease. And like I said, with Crohn's disease, it can really affect anywhere in the GI tract. So let's take a picture. Let's look at a picture of it. With ulcerative colitis, it usually starts at the rectosigmoid area of the anal canal, and then it progresses proximally. So starts here and kind of goes this way, right? And it's inflammation at the base of the crypts of Lieberkühn. This crypt causes these abscesses, and it kind of goes through the mucosa and spreads laterally. So there's kind of like these pussy exudates, and they release the inflammatory process, and then there's further tissue damage. And then after a long period of time, you can have atrophy of the colon. So this is a healthy looking colon. This is an ulcerative colon. To me, it's a little bit confusing because with Crohn's disease is where you actually have the ulcers, and with ulcerative colitis, you actually have these pussy abscesses. So it's a little bit opposite of what you would think. So this is what it looks like. Here's what it looks like as well. I have lots of pictures in these lectures, so I hope you enjoy them. The pathophysiology and etiology, this is a normal intestine, and this is Crohn's disease. So with Crohn's disease, it starts as this small little aphthoid lesion, which actually looks like a little ulcer. And then those ulcers can progress into all the different layers. You get deeper ulcerations and lesions and sometimes fissures, but they're not continuous. So it'll be just like these little individual places. And then you have the fibrotic changes. So see, this starts to take over. So that wall gets thicker and thicker. And then this little, it's like a cobblestone-like appearance, that area gets smaller and smaller. So you have malnutrition and malabsorption because those ulcers prevent you from absorbing the nutrients that you need, and then also protein loss. So mild disease with Crohn's disease is fewer than 4 stools a day. Moderate disease would be 4 to 6 stools per day. And if you have more than 6 stools a day with ulcerative colitis, that is considered severe disease. I think that's probably all we need to know about that. So the etiology is really unknown for these diseases. We think a lot of different things. We think there might be genetic causes. We think there might be environmental causes. We think there might be some autoimmunity issues, but we're not really sure. Lifestyle factors, smoking may play a role, and we'll talk about that a little bit more. So what are the risk factors for inflammatory bowel disease? Well, it occurs mostly in the United States and northern European nations, and American Jews of European descent are 4 to 5 times more likely to develop inflammatory bowel disease. African Americans and Caucasians are more likely to develop inflammatory bowel disease. Prevention is really trying to avoid or stop smoking, although smoking can increase the risk of developing Crohn's disease, but for ulcerative colitis patients, it becomes worse if patients stop smoking. So that's interesting. Anybody who uses nonsteroidal anti-inflammatories or antibiotics, that can increase your risk. So let's talk about clinical manifestations. Well, with ulcerative colitis, diarrhea is the prominent one, and it's actually bloody diarrhea, and mucus is probably the distinctive thing about ulcerative colitis. You can have a lot of stools with ulcerative colitis, more than 6 a day. They can also have rectal bleeding, mucus, but it doesn't really bother the rest of the body as much as Crohn's disease does. With severe ulcerative colitis, you can have 6 to 10 bloody stools a day, lots of involvement with the colon, anemia, of course, from losing the blood, hypovolemia from losing fluids, all that loss, malnutrition, rectal inflammation, of course, fecal urgency, and that is pretty distinctive. Tenesmus is when they have this painful but ineffective urge to defecate. And then left lower quadrant cramping relieved by defecation. And like we talked about with ulcerative colitis has an L right there, so that's the left side of the body. With Crohn's disease, the second letter is an R, so that reminds me that pain is usually on the right side of the body. That's one of the ways that I differentiate the two myself. So in severe ulcerative colitis, you can also have fatigue, anorexia, weakness, and the systemic manifestations, if you have them, would be like arthritis, uveitis, emboli, thromboemboli, and sclerosing cholangitis. So one of the things that can happen with ulcerative colitis is hemorrhage, so of course bleeding, and then perforation and rupture of the bowel. And we need to be really aware of that because that's a medical emergency. And some patients develop fulminant colitis or toxic megacolon, and there can also be colon perforation. All those things, and that can put you at increased risk for colorectal cancer. So recurrent ulcerative colitis is the most common form of ulcerative colitis. And let's see if there's anything else. Chronic intermittent colitis is an acute form of the disease that can involve the entire colon, so that's a little bit more serious. And the bloody diarrhea, abdominal pain, and fever would accompany that. Okay. In Crohn's disease, the symptoms are a little different depending on what different kinds of things are going on. You can have the persistent diarrhea. Typically with Crohn's disease there is not blood. And then abdominal pain, this time it would be on the right lower quadrant, and it is usually relieved when they go to the bathroom. And then in Crohn's disease you can also have a mass in the right lower quadrant. There are systemic manifestations with Crohn's disease like fever, fatigue, malaise, weight loss, and anemia. Some complications of Crohn's would be an obstruction, an abscess, fistulas, again, perforation of the bowel, and that's a problem because then all those fluids are going in the wrong spot and you can get peritonitis and also recurrent urinary tract infections. Perforation is not as common with Crohn's though. So we have to have a diagnosis and figure out how bad the disease is, and then treatment is kind of supportive. Medications to decrease inflammation, intestinal rest, and healing. Okay. So what are some diagnostic tests that we do? Well, we do a sigmoidoscopy, colonoscopy, or barium upper lower GI series. The lab test would be a stool examination, a CBC, a SED rate, albumin, serum levels of vitamins, liver function test. And surgical options. Really don't want to do this unless it's absolutely necessary because of complications. If you have a bowel obstruction, that is probably the leading cause of surgery in Crohn's disease. If there's a perforation, obviously we need to take care of that. Internal, external fistulas, abscesses, and sometimes, we'll talk about that here, a colectomy is, you can have a total colectomy done. Let's see if I can pull this down or up. There we go. You can have a total colectomy with an ileal pouch. So it's like it's an ileostomy basically, and then an anal anastomosis. Here's a picture. So here's what your bowel normally looks like, and then they take it all out here, and then they pull this through, and you can have a ileostomy. And we treat it very similarly to a colostomy, but it really depends on where the stoma is as far as what we call it. That'll treat the disease and eliminate complications like the toxic megacolon, perforation, or hemorrhage, and also serves as a prophylactic measure against high colon cancer risk, which is associated with ulcerative colitis. And they'll sometimes do just a temporary ileostomy to allow that to heal, and then they re-anastomose it after it has had a chance to heal. So these are the different kinds of ileostomies that you can have. So what do we do pharmacologically? Well, the goals are really to kind of terminate the acute attacks, right, and allow the relapse to happen. And medications that we use are anti-inflammatories for mild to moderate disease, immunosuppressants for severe disease, or corticosteroids if they're in the middle of an acute exacerbation. Some of our immune response medications, the immunosuppressants, would be like Remicade or Humira. I think it's infliximab is the other name for Remicade, and adalimumab is Humira. I'm sure I'm not saying that correctly, but another immunosuppressive agent is mercaptopurine. Those are all when patients don't respond to other measures. And then sulfazazine acts topically on colonic mucosa to inhibit the inflammatory process and try to get that under control. So other medications that we might use, of course, antibiotics when there's an abscess, antidiarrheal agents to kind of like loperamide or diphenoxylate. Those slow the motility and try to reduce the diarrhea because that's a big problem for them. And it's really important to stress that their medication regimen is important even if they're not having symptoms to prevent further symptoms, right? Non-pharmacologically, we think that there may be some antigens in the diet that stimulate immune response in the bowel and make inflammatory bowel disease worse. So if they can try to work with a nutritionist who's working with the healthcare provider to see what those triggers might be for them. It might be milk or milk products. It might be increased fiber. If a patient has strictures, that's not a good option for them. If they're having an acute exacerbation of Crohn's disease, they may have to not have food for a while, maybe on TPN or elemental diet. So some alternative ideas. Some probiotics they think may improve symptoms of inflammatory bowel disease. There's not a lot of good evidence to support that, and the problem with probiotics is the same with all herbal remedies and supplements, and that is that they're not regulated by the FDA, and so not all the products have the same ingredients, and so they don't all have the same effects because they're not really regulated, and the lack of research doesn't really prove one way or the other. So it's important to limit use of herbal supplements and make sure that our patients tell us everything that they might be on, tell the primary care provider every product that they might be on, even if it's over the counter or supplement. Okay, so it's more common in males than in females as children and adolescents, and children have Crohn's disease more often than ulcerative colitis. Again, Crohn's starts with the C, so that's how I remember that happens mostly with children. The opposite is true in adults. More adults have ulcerative colitis than Crohn's, and really where they have it differs. Primary management is objective. Really just depends. Mild disease, again, they're going to use aminosalicylates. Moderate disease, corticosteroids. Surgery, hopefully they can do a laparoscopic approach. And then, of course, malabsorption is a problem with children, and we see that in failure to grow. They may do some dietary supplements along with medications, and patient teaching is important, especially regarding their diet. Pregnant women, gastroenterologists must educate patients proactively before they plan pregnancy. They have an increased risk of preeclampsia, preterm delivery, premature rupture of membranes, and infants with low APGAR scores or congenital malformations. In older adults, we see ulcerative colitis a lot more, and it's treated often with immunosuppressive agents. Let's see, so we want to try to help our patients avoid complications. That would be a big part of the nursing process, and stress the importance of complying with medications and to report their symptoms as soon as they see them so that exacerbations can be treated pretty quickly. Assessment, obviously we're going to look at the number of bowel movements a day, onset, duration, and severity of their symptoms, their diet, what their weight is like, food intolerances, all those different things, vital signs. And then with the abdomen, we're going to look at the size and shape and contour, look for bowel sounds, palpate for tenderness of masses. Remember with Crohn's, they can have that right lower quadrant mass, and then also look for stomas or scars. Diagnosis is that you would see the normal ones you would think of for nursing diagnosis about fluid volume, nutrition, constipation, diarrhea, pain, body image, of course. So what are we going to try to do for these patients? Well, we want to try to get them back to a state of remission, get rid of those symptoms, keep them hydrated, and have optimal nutrition status, right? And positive, healthy coping skills, also demonstrate for them appropriate home self-care and make sure that they're able to do that. Teaching is going to be a really big part of it. Diarrhea is a problem, and so disturbed body image is also a problem. And especially children and adolescents have special needs because of the body image part. Can you even imagine having to be at school and having more than 6 bloody stools a day? That would be awful. So that's obviously a big problem. And of course, nutrition comes right along with that. So monitor fluid volume is really important, making sure that with this frequent diarrhea that we record how often it's happening, and also use a stool chart to talk about not just the amount and frequency, but also what it looks like. I mean, if it's diarrhea or it's soft stool or firm stool, and then daily weights and other fluid volume indicators. Sometimes we want to give bowel rest, so we'll keep them NPO and limit their oral intake. Medicines as ordered, fluid and IVs, however it's prescribed. Good skincare, of course, skin integrity is going to be an issue when you have that many bowel movements. And discharge teaching. They might be frustrated, obviously. They might have problems with self-image, obviously. So you're going to want to encourage discussion about all of these changes and talk to them about different choices that they might have and promote healthy body image. We also really want to monitor lab values, of course, provide the diet that's prescribed and the nutrition as necessary, dietary consult if necessary, and administer elemental nutrition as ordered. And of course, keep the family involved as well. So what do we want to see? Of course, same as always, we want them to not have GI distress. We want those symptoms to decrease. We want them to be able to go about their activities of daily living without too much impact on their life. Medications, they're going to have to manage those and hopefully not have too many side effects. We can hopefully avoid signs and symptoms of infection, have a positive body image. Relaxation techniques may help them as well, so maybe they can integrate those into their normal life. And then finally, if they don't progress satisfactorily, we're going to do a thorough assessment just to make sure there's nothing else going on. Pain level, diet tolerance, vital signs will all be imperative to do. IV fluids, pain medication may be reinstated if they're not getting better. They might have to be NPO for a while or have some IV antibiotics. May need a surgical consult if nothing else works. And so we're going to make sure that we're prepared to do all of those things. And believe it or not, we're already at the end of inflammatory bowel disease. I hope that answers a lot of your questions. Feel free to email me if you have any more questions. I promise in the next lecture I have some really great pictures, so I'm excited to be doing that next. Have a good one.